So first of all, I will like to thank Professor Vitul Gupta and the organizing committee for inviting me for this talk. So as Dr. Karamveer already highlighted the importance of lipid control in the general population, so I will be speaking mainly about dyslipidemia in the diabetes. So actually it is lipids are very important to treat in a diabetic patients, but practically if we see, so whenever any doctor prescribes statins to the patients, so first treatment which patient stops is statins. They themselves stop after some time. So our duty is to tell them the importance of lipid medication so that they otherwise they come up with all the cardiovascular disease and other MI and other things. So now I will be speaking about LAI guidelines for the management of diabetic dyslipidemia. So India is one of the diabetes capital of the world, and estimated in 2021 there were 74 million population suffering from diabetes. And why Indians are different? We are having from the Western population, we are having earlier age of onset of diabetes, higher frequency of metabolic syndrome, and more risk factor for ASCVD and more aggressive course of ASCVD complications. So we are different from Western population. That's why under the leadership of Dr. Raman Puri, the LAI guidelines were formulated for diabetes, and there were more than 165 webinars were done to formulate these guidelines. So I am one of the co-authors in these LAI guidelines. So after so much of efforts, these guidelines were made. So what are the objectives for LA recommendation? Why we made these recommendation? Because we are different from the Western population. So our main aim was to reduce the cardiovascular morbidity and mortality in Indian patients, because the main cause of mortality in diabetes is CAD. And there is a lot of under treatment of dyslipidemia from the doctor's point of view also, and from the patient point of view also, because patients think that this is the unnecessary medication. So they tend to stop the statins. And for the unique features of diabetes dyslipidemia, these guidelines were made so that we can reduce the morbidity and mortality. And we are having younger age of onset of diabetes, and more than 90% of Indian patients are having less than 50 age, and the risk factors hypertension, obesity, dyslipidemia and ischemic heart disease are quite prevalent. And according to ICMR study, typical age of onset of diabetes in Indians were in between 25 and 34 year of age. And Asian Indians are having higher prevalence of metabolic syndrome. If you see this Masala study, that is mediators of atherosclerosis in South Asian living in America. So South Asian Indians were having prevalence of metabolic syndrome to the tune of 20 to 32%. And we are having elevated body fat mass, often with normal body weight, which is the classical YY paradox if you see in the Indian patients. And despite normal BMI, we are having higher fat mass, visceral fat, higher insulin resistance, dyslipidemia and heightened risk of type 2 diabetes, and also having higher waist and higher waist to hip ratio. And we are also having higher abdominal and ectopic fat and lower lean body mass. And if we see the higher prevalence of atherosclerosis, it was to the tune of 21% as compared to non-diabetics, where it was 11%. And in Indian patients, diabetic patient, 3 to 4 times higher risk of cardiovascular disease is there. And dyslipidemia precedes the diagnosis of diabetes. So the prevalence of atherogenic small dense LDL, even if LDL is normal, this atherogenic small dense LDL 18 to 20 nanometer size, which can be seen by NMR spectroscopy. So this is risky for the development of cardiovascular disease. So in the diabetic patient, it is the characteristic dyslipidemia, that is hypertriglyceridemia, low HDL and small LDL particle without elevation of LDL, but elevated non-HDL cholesterol. Non-HDL cholesterol is also one of the important parameters for the development of cardiovascular disease. And mostly non-HDL is not given that much of importance. Most of the people are focusing on triglyceride and LDL, but non-HDL is also one of the important parameters which is more predictive of risk than the LDL. So, how to calculate this? You subtract HDL from the total cholesterol, that comes the non-HDL cholesterol value. So, this is rather more important parameter than the even LDL cholesterol. So, if we go about the studies of effect of lipid lowering medication on CVD risk in diabetes, that is statins and ezetimibe. So, heart protection study, it was seen that if you treat lipids, the protection with simvastatin was more in diabetes as compared to patient without diabetes, and similar findings were seen in 4S study, that is Scandinavian simvastatin survival study. So, benefit in diabetic patients were more as compared to non-diabetic patients. Even treating to new target study, that is TNT, if you compare 80 mg dose of Atorva versus 10 mg, so the patients who were given 80 mg dose, there was much better improvement as compared to the 10 mg dose. And improve IT trial in which simvastatin was combined with ezetimibe, and there was event rate was better improved if you combine simvastatin with ezetimibe. So, there was definitely much better improvement in patients with diabetes and established ASCVD. So, the main findings from all the trials were lower you go for the LDL, the better the protection for the development of cardiovascular disease. So, atherogenic triad we have already discussed. So, lipid association of India guidelines say that even if you control the LDL, still there remains the risk of cardiovascular disease, 30 to 40% risk still remains. So, SGLT2 inhibitors are one of the drugs of choice for the prevention of cardiovascular disease in diabetic patients, so which can help in the prevention of cardiovascular disease. So, SGLT2 inhibitors are the one of the adjunct therapy, and similarly GLP-1 receptor agonists are coming in a big way. They improve the CV mortality, but they do not improve the non-fatal MA and heart failure, and also they help in prevention of cerebrovascular disease, and they are also renoprotective. So, LI recommendation says that SGLT2 inhibitors and GLP-1 receptor agonists are one of the adjunct therapy for prevention of cardiovascular disease in diabetic patients. So, now coming the role of the PCSK9 inhibitors. So, which are the injectable drugs. So, Odyssey outcome trial and Fourier trials, these were two trials in which persons with pre-existing ASCVD, of which 40% of patients had diabetes, they were treated with evolocumab 140 mg subcutaneously twice a week, and LDL was lowered to 30 milligram per deciliter. So, there was a 15% relative risk reduction of composite primary endpoints at 2 years. So, you just see that LDL was lowered up to 30 milligram per deciliter, still there was much improvement. So, as Dr. Kanavir also already told, so lower the LDL, the better it is for the patient. And in patients of diabetes with dyslipidemia, PCSK9 inhibitors can be useful option for management of refractory hypercholesterolemia. Sometimes you are not able to control LDL with statins or ezetimibe or bempedoic acid. So, PCSK inhibitors, although these are costly treatment, but they are one of the good options in patients in whom you are not able to control the LDL levels. And if you combinedly treat dyslipidemia, hyperglycemia and hypertension, you can reduce the risk of CVD by 62%. And so, there are lot of gaps in global guidelines. That is why the rationale was there for recommendation for the treatment of dyslipidemia in diabetes in Indian patients by the Lipid Association of India, because we are unique, we are different from the Western population. So, if we see the LI 20 guidelines, so diabetes with less than one major ASCVD risk factors without target organ damage. Our aim is to lower LDL to less than 70, non-HDL less than 100, and ApoB should be less than 80. And diabetes with more than 2 risk factors and no evidence and evidence of target organ damage, LDL should be less than 50. Non-HDL should be less than 80 and ApoB should be less than 65. And extreme risk group category A, ASCVD and diabetes with less than one major risk factors without target organ damage, LDL should be less than 50 and non-HDL less than 80 and ApoB should be less than 65. And extreme risk category, category B, which is CAD and diabetes with more than 2 major ASCVD risk factors or target organ damage. So, LDL should be less than 30 and non-HDL should be less than 60 and ApoB should be less than 50. So, just see that in a diabetes patient with ASCVD, our target should be at least LDL should be less than 50. So, if you see in your practice also, many patients already having MI or any stunting CABG, our target of LDL should be less than 50 or less than 30 if patient is having more than 2 risk factors. So, such is the stringent criteria of lipid association of India in the Indian patients. So, this risk certification Dr. Karamveer has already told, so I am not going into the details of this. And one of the trials in Improve IT trial, they achieved LDL less than 30 in 6% of patients. So, there was 29% lower risk of CV events. So, just imagine that LDL less than 30, still you are having around 30% improvement in the cardiovascular events. And similarly, Osler studies and Odyssey trial in which PCSK9 inhibitors were used. So, LDL was maintained less than 50 and there was much more improvement. So, Evolocumab, which is a PCSK9 inhibitor, so it can lower the LDL to any level less than 30, 20 up to that. So, these PCSK9 inhibitors, these are the drugs of future. So, they will be used in future quite extensively when cost comes down. And one of the meta-analysis of non-statin trials, it was seen that if you lower LDL up to even 20, so further you can reduce the CV risk and there was not much of harm to the patient. So, even if you go up to 20 also, there was no harm, rather there was a improvement in the parameters. And if we see Odyssey outcome trial, ultra low LDL level of less than 15 was achieved in 7.7% patients and there was a risk reduction to the tune of 29%. So, one of the most important parameter is lifestyle modification, which is the cornerstone of ASCVD prevention. So, diet, Dr. Karamveer has already discussed, diet should be rich in PUFA and MUFA. And mustard oil and canola oil is the oil which is most suitable oil for routine use in Indian cooking. So, this point was specifically highlighted in the Lipid Association of India. So, if patient comes and asks you, mustard and canola oils appear to be the one of the best oils for routine use in the Indian kitchens. And cold pressed oils are better because they retain the antioxidant and micronutrients. So, nowadays lot of trend is there, cold pressed oils are used. So, these are better than the conventional oils. And alcohol should not be used much in the patients for prevention of hypertriglyceridemia. Physical activity 150 minutes per week of moderate physical activity should be there. So, now coming to the guidelines of LAI. I will be discussing this thing in 2-3 slides, last 2-3 slides. So, diabetes, how to manage diabetic dyslipidemia in Indians, diabetes without ASCVD. So, first of all you have to see whether any target organ damage is there or not, or less than one risk factor is there. So patient becomes the high risk. So LDL is less than 70. So diabetic patient as such is a high risk patient. So any patient without any damage, without any risk factor, any diabetic patient coming to you, you should maintain LDL level less than 70. If patient is having target organ damage like any heart problem, retinopathy or any CVA or any microalbuminuria, smoking, etc., risk factors are there, more than 2 risk factors are there, patient becomes very high risk. So LDL should be maintained less than 50 in such patients. So in our practice, in our diabetic patient, most of our patients fit into high risk or very high risk category. So our aim is to maintain LDL at least less than 50 in such patients. And if patient of diabetes is already having ASCVD, and you have to see associated comorbidities, that is diabetes without target organ damage less than 1 major ASCVD risk factor, that patient becomes extreme risk group category A. LDL should be maintained less than 50 and optional is less than 30. And if patient is having diabetes plus polyvascular disease or target organ damage more than 2 major ASCVD risk factor, that becomes extreme risk group category B. So LDL should be maintained less than 30. So first category is diabetes without ASCVD, which is the general, everybody, physicians, endocrinologists, everybody sees, and diabetes with ASCVD, which is mostly cardiologists see such patients. So there you have to maintain LDL either less than 50 or less than 30, otherwise in the general practice LDL less than 70 and less than 50. So that should be our goal in the majority of the patients. So this is the summary of the lipid association of India guidelines. Then comes the triglyceride targets. So triglyceride, if in between 150 to 199, 200 to 500, 500 to 1000 and more than 1000. So how to treat? So you have to measure LDL level, calculate known HDL, assess the ASCVD risk, lifestyle modification in the form of low fat diet, avoid refined carbohydrates, weight reduction, exercise, avoid alcohol, no smoking, and first of all if patient is having increased LDL, increased non-HDL and high ASCVD risk, you have to treat with statins and ezetimibe and achieve LDL target. If you are not able to achieve the triglyceride target like more than 135, then you can add omega-3 fatty acids or fibrates. If triglycerides are more than 500 to 1000, so straightway you can add fibrates or omega-3 fatty acids, and more than 500, if TG is there, risk of pancreatitis is quite high, and if it is TG is more than 1000, then there is marked increased risk of pancreatitis. So we don't wait. If TG is more than 500, straightway you can add fibrates, and standard treatment should be continued, that is statins plus ezetimibe, that should be continued. Sometimes if triglycerides are quite high, 3000, 4000 or 5000, so plasma apheresis also in some centers in Delhi they are doing. So that is one of the options for that also. And lie recommendation for non-HDL is like whenever any patient comes to in OPD and you don't require a fasting lipid profile. Straightway you can do the lipid profile and you can measure the non-HDL cholesterol, and the target of non-HDL cholesterol is 30 milligram higher than the LDL. So according to that also you can put the patient on statin. So fasting lipid profile is not mandatory. It is better to do a lipid profile rather than not doing it, because many times you write the lipid profile, patient won't come back to you. So straightway you can go for lipid profile estimation without fasting also. And statins remain the first drug of choice, and addition of ezetimibe can be considered if you are not able to control HDL or non-HDL. So ezetimibe, I think it is a good molecule. It is underused, but now again people have started using ezetimibe. In between people were not using it much, but this is one of the good molecule for lowering the LDL cholesterol levels, because sometimes patients don't tolerate the high dose of statin, so you can add ezetimibe and you can achieve the LDL cholesterol. And ecosap and ethyl is available in India now for the management of higher triglycerides. And our aim is to maintain triglyceride less than 150. So I am not going into much of the details of triglyceride, because that we already discussed. And one of the important parameters is ApoB concentration also. So that should also be lowered. It is also one of the important parameters. And ApoB should be measured in high risk and extreme risk groups after LDL and non-HDL goals have been achieved. And lipoprotein little a also should be measured in extremely high risk and high risk patients. And there is not much of treatment available for treatment of LPA, and PCSK inhibitors can be one of the good choice for treatment of LPA. Otherwise, statins and ezetimibe, they don't lower the LPA too much. So PCSK9 inhibitor can be a good choice for prevention of cardiovascular disease. So now I will end my presentation by this summary. So diabetes with no ASCVD and diabetes with ASCVD. So this we already discussed, that high risk group LDL should be less than 70. Very high risk group LDL should be less than 50. Diabetes with ASCVD with no risk factor LDL less than 50. And diabetes with ASCVD with more than 2 risk factor LDL should be less than 30. So lower the LDL, the better it is for the patient. So thank you all for your patient listening.